to move on a little bit, there's a lot of prognostic factors that we as a community have looked at over the last 30 years through large retrospective studies. And I think, it would be good to discuss what actually is prognostic in terms of outcomes.
Sure. Well, I'd add that the AJCC is now coming out with its 8th edition, and that will be very informative, and I won't steal the thunder of that moving forward. We encourage everyone to read it, of course. But we know grade of tumor, size of tumor matter, but bigger is worse, higher grade is worse. But I think biology, as we're sort of resonating here, is really a driver. So I always, when I'm giving lectures to trainees in sarcoma, I'm always emphasizing I would much rather have a very large, deep-seated, well-differentiated liposarcoma than a little ulcerative epithelioid sarcoma on my hand. So the biology really does drive the behavior in many ways. Controlling for biology, smaller and lower grade is better.
Well, I think one of the things that I think a number of us have already echoed is really the importance of multidisciplinary care. And I think the NCCN really does come out with a very nice statement which says that patients with sarcoma should be managed but not necessarily treated by a multidisciplinary panel with heavy experience. The right recommendations could be just really altering for a patient in terms of their outcome. And so it's really important right up front to make sure that the right plan's put in place. And so I'd kind of like to get everybody's, feelings about the need for multidisciplinary care. And I think, the person who may drive a lot of this would be the surgeon. And so for that, I'd like to pose my first question to you, Laura, which is, what are the challenges involved in, really diagnosing and building a team for everybody with soft tissue sarcoma?
Thanks, Brian. It is a challenge. While we always retrospectively say, gosh, I wish this person had been treated by us initially, we also don't want every little lipoma and lump and bump coming to a sarcoma center, because then we would dilute our resources and compromise care, therefore. So that in and of itself is a challenge. We would ideally like to screen everyone, but we can't screen everyone. This is a very practical challenge. Having said that, when referred to a center, it really is very important that there is a seamless integration across disciplines. And as a surgeon, I need to understand the biology, the medical oncology, the radiation therapeutics available, the leading edge thought. And I would say that the people the physicians that are involved in more the systemic management also need to understand the local control issues, because we know that surgery and radiation therapy are backbones, no pun intended, for curing and managing sarcomas. And so getting people together, having a common cause, and managing these patients is a full-time job, really.
I'd like to echo that one modality can optimize the use of another, and it's important to have everybody together making decisions so that the pros and cons of each approach can be adequately addressed.
Yeah, we really pride ourselves on our tumor board, make sure every discipline is there, and even if it's a chondrosarcoma or liposarcoma, where we know that surgery is going to be perhaps the exclusive treatment, we want everyone to weigh in, because we know that there's going to be potential local relapse or systemic relapse. And I think it engages everyone and gets everyone thinking.
And it also provides the opportunity to look at new approaches or new treatments in a group setting. One discipline might have a new study, so a new drug coming along that might be given neoadjuvantly, or a randomized study of radiation, for example, in part of the treatment of retroperitoneal sarcomas might come along. So having that multidisciplinary approach is very important to keep each other informed as well about different approaches to treating the tumor.
And we can be each other's conscience and keep each other in line, right?
Yes.
I think we can be the best critiques of our colleagues. We can be the best physicians in making treatment decisions if we understand the abilities and limitations of our colleagues in other disciplines. So it is absolutely of paramount importance that the group of physicians, specialties treating this disease, have a forum of sitting around a table and discussing these cases, outline the plans of treatment at the very beginning, and then carry it out, rather than playing football where you keep punting from one person to another, and that clearly does create some serious problems.
And I'd add, too, that these can be really complicated. We all know this, and that it's not just within our own centers that we discuss these things. And I mean, it's not unusual for us to send emails or call each other up and say, hey, what would you do with this? Because they are really challenging cases, and,
Well,
and it
yeah,
needs other minds involved too.
the complexity, both in terms of heterogeneity, rarity, and the wide variety of anatomic primary sites, just make it very, very challenging to.
I feel like we're scaring everyone away from treating these now.
One of the other advantages of a multidisciplinary conference, which we put all of our sarcoma patients through for discussion, is the timing. If you see a patient with a newly diagnosed Ewing sarcoma or rhabdomyosarcoma, you don't want to get a consult from a medical oncologist and then a radiation therapist and then a surgeon sequentially over 6 to 8 weeks. You want to present that patient as soon as they're diagnosed with the entire multidisciplinary team, implement a treatment of action, perhaps admit the patient to the hospital rapidly so that you can get the appropriate therapy initiated in a timely fashion, because some of these sarcomas, particularly the small cell sarcomas, can grow quite rapidly.
Yes, exactly, the real-time discussion and, as I say, the optimization of each modality in real time.